An elevated office blood pressure reading is the most common trigger for cardiovascular intervention. Yet this measurement is notoriously susceptible to physiological and mechanical artifact. Because of this risk for artificial elevation, a single elevated intake reading is no longer clinically sufficient to diagnose hypertension. This introduces a core conflict into modern practice. Hypertension management has fractured into two competing schools of thought regarding the actual treatment thresholds. In 2017, the American College of Cardiology and the American Heart Association aggressively redefined the hypertension threshold down to 130/80. This policy drastically expanded the eligible patient pool. Contrast this with guidelines from the American Academy of Family Physicians and the JNC-8, which maintain the older, more conservative threshold of 140/90. To mitigate the physiological risks of overtreatment, the JNC-8 guidelines even push the intervention threshold up to 150/90 for adults over the age of 60. How does a clinician navigate these conflicting mandates to establish a safe, effective treatment target for the patient sitting in the exam room? Navigating these numbers requires moving past simple thresholds and into a logic tree that filters a patient's risk factors to find their specific target. An elevated cuff reading is only a warning light. Rigorous clinical management demands a structured verification and escalation pathway before initiating lifelong pharmacotherapy. The first required phase of this algorithm is diagnostic verification. Looking at this clinical flowchart, the first logic gate triggered by an elevated reading is a manual repeat measurement. If still elevated, the clinician must neutralize the Lies code effect. This requires moving to out-of-office confirmation using self-measured blood pressure or ambulatory monitoring. White coat hypertension describes high office readings coupled with normal home readings. It carries only a minimally increased cardiovascular risk. The inverse scenario is masked hypertension, where office readings appear normal, but out-of-office measurements are chronically elevated. The cardiovascular risk of masked hypertension equals that of overall clinical hypertension. Self-measured monitoring is vital for catching these missed cases. True hypertension cannot be diagnosed in a vacuum. It requires longitudinal, out-of-office data points to validate the physiological risk and justify medical intervention. Once the diagnosis is verified, the clinician must select a treatment target. This step requires weighing conflicting clinical trial data. The primary catalyst for the ACC and AAA's aggressive 130/80 target was the SPRINT trial. This line chart tracks the SPRINT trial. Intensive control below 120 lowered the cardiovascular event rate to 1.65% versus 2.19% for the standard group. But secondary data reveals the cost of this aggressive target, a significant spike in serious adverse events. Specifically, the data showed sharp increases in hypotension, syncope, and acute kidney injury. This precise risk profile is why the JNC-8 and AAFP refuse to endorse lower diagnostic targets for older or frail patients. The clinician has to weigh the patient's actual biological age and kidney function against abstract metrics like a 10-year ASCVD risk. Treatment targets must be individualized. Chasing aggressive numbers might improve cardiovascular statistics on paper, but it can physiologically crash a vulnerable patient in practice. If lifestyle modifications like the DASH diet and sodium reduction fail to reach the target, algorithmic pharmacotherapy begins. The JNC-8 algorithm starts by evaluating chronic kidney disease. If present, therapy must initiate with an ACE inhibitor or ARB to protect renal function. Contrast this with the Black population pathway, which dictates initiating a thiazide-type diuretic or a calcium channel blocker. Meanwhile, the non-Black general population pathway permits initiation with any of the four primary classes: a thiazide, ACE inhibitor, ARB, or calcium channel blocker. While the JNC-8 splits initial therapy by race to match historical population data, this approach treats a broad social category as a biological absolute. It ignores the specific genetic markers and social determinants that actually dictate how an individual processes a medication. Newer diagnostic frameworks, like the AHA Prevent Risk Calculator, are actively removing race from the risk assessment equation entirely. Agent selection remains a deterministic process driven by physiology and renal function. Deviating from the algorithm without clinical cause invites uncontrolled pressure and end organ damage. This leaves a final clinical hurdle. What is the protocol when the algorithm fails and the patient's pressure remains above the target? This condition is defined as strict resistant hypertension, blood pressure that remains uncontrolled despite the concurrent use of 3 antihypertensive agents from different classes. There is a critical caveat here. These drugs must be prescribed at their maximum tolerated doses, and one of the 3 must be a diuretic. Before escalating treatment, the clinician must rule out pseudo-resistance. This means confirming strict medication adherence and verifying proper cuff technique in the clinic. It also requires a thorough medical audit to identify and eliminate offending chemical agents, specifically things like NSAIDs, like common sympathomimetics, and estrogen-containing oral contraceptives. From there, the protocol requires screening for secondary physiological causes, including primary aldosteronism, obstructive sleep apnea, and renal artery stenosis. The pharmacological salvage step for true resistance is adding a mineralocorticoid receptor antagonist, such as spironolactone. If 5 or more medications fail to achieve the target, the patient transitions to refractory hypertension, necessitating an immediate referral to a specialist. Managing chronic hypertension is a relentless, algorithmic process. Success depends on validating every data point, targeting specific demographics, and systematically eliminating the physiological interference that masks the true